Kajala Medical presents COVID-19 The Answers, the show that delivers the scientific, evidence-based knowledge that can safely return us all to our pre-COVID lives. My name is Dr. Fumi Okanola, and I'll be hosting the show. Every week, you can listen to me interview a highly respected professional about the science that can reduce your risk of becoming infected with this coronavirus. Hello, and welcome to episode 3 of COVID-19 The Answers. Today, I would like to introduce you to Dr. Jason Maley. Dr. Maley is an epidemiologist and specialist physician in pulmonary care and critical medicine. He is director of Beth Israel Deaconess Medical Center's Critical Illness and COVID-19 Survivorship Program in Boston in the United States. He is an instructor in medicine at Harvard Medical School and co-chair of the American Academy of Physical Medicine and Rehabilitation Post-Acute Sequelae of SARS-CoV-2 Collaborative. He has come to talk to us today about long COVID. Welcome. Jason, would you like to tell us a bit about yourself? Your resume is quite diverse. How did you come to be an epidemiologist and also a physician for COVID-19 survivors?
Sure, thank you for having me. So I came to be focused on this really initially through my work in the intensive care unit following patients and families after they survived critical illness before the pandemic, and had an interest in both understanding the challenges of recovering from especially a respiratory illness like a pneumonia and how to help people recover best. And with the pandemic and the number of people we were seeing in the ICU, and then recognizing this entity, long COVID, the sequelae that people were having, even after mild COVID, we knew that there was an important need to help these patients recover and a need to understand it better and to get to the bottom of why people were experiencing this. So it was kind of a natural extension of my pre-pandemic outcomes work, shifting into now understanding recovery from COVID-19.
That's fantastic. And I must say, just thank you for all that you do. We across the world truly appreciate physicians such as yourself that have approached this whole sort of pandemic disaster with such bravery and focus. Really appreciate that.
Thank you.
So I'm going to now get down to the questions, and we're going to really talk about long COVID. So long COVID is estimated to affect 15 to 30% of all non-hospitalized people that get COVID-19 and around 80% of people hospitalized with COVID-19. To give the audience an idea on numbers, with over 3 million Canadians infected with COVID-19 to date, we would expect around 0.5 to 1 million people to develop long COVID. In the USA, nearly 78 million people have tested positive for COVID-19. This would equate to around 12 to 23 million people developing long COVID. Staggering figures. So after a viral illness, we can expect to be a little run down for a few weeks as our immune systems recover. Bearing this in mind, what is long COVID and how does it differ from this presentation?
Great. So you're right, after having a typical virus, having a cold or even having the flu, most people will feel kind of run down for days to weeks, but then they'll recover and they'll feel essentially like they get back to their normal routine. Their energy is normal, their sleep normalizes, they're able to work, their thinking hasn't changed, and certainly they're not having new unexplained symptoms like pains or changes in their taste and smell that has not returned, those types of things. So where long COVID differs is as people are recovering from the initial illness, the acute illness, having COVID-19, in the weeks to months after that, usually people recognize around 4 to 12 weeks, they haven't recovered the way they would expect, or there are new things that they're noticing, such as the shortness of breath that they had when they first had COVID hasn't gone away. And they were previously athletic and active, and now they feel short of breath walking around their house. or their heart races when they walk around, or they haven't been able to return to work because their thinking and their memory and their ability to multitask and organize and focus is completely off, and they really can't function. So those, along with many other things head to toe, are persisting in a way that you wouldn't expect for someone who had recovered from a virus and whose body had returned to normal. So there's clearly a change that hasn't returned to normal and is causing this injury.
Thank you. Has there been a viral disease causing this proportion of chronic illness in a population in recorded medical history?
So it's tough to say exact numbers, but one first reference point is prior to this pandemic, this type of syndrome, post-acute infection, post-acute viral syndromes causing impairments like long COVID, have been described for centuries, actually. They were given a variety of different names because the farther back in time you go, the less understanding they had of medicine. And similar, unfortunately, to what we're seeing with long COVID, at that time, people were also kind of brushed aside as this isn't real, or you need to get over this type of mentality. But people having changes in cognition, persistent fatigue, unexplained pains, and other symptoms like we're seeing with long COVID has been described with other viral pandemics and after other infections. So it's hard to know if we're simply recognizing it and it's getting this attention because of the scale of the pandemic and the fact that so many people are being affected. And we're in the age of modern medicine and communication and connectivity across the world so that we can actually see that scale in a way that wouldn't have been possible during a pandemic at the beginning of the 20th century or during pandemics at other times. So I don't know the exact comparison to others. I think it's been seen before, but certainly the scale is something that we've never at least had recorded in medical history.
Oh, excellent points. Long COVID is known to present with a myriad of symptoms. Over 200 symptoms in a paper I read last year, ranging from fatigue to heart arrhythmias. In your clinical experience as a physician, closely working with this patient group, what are the most serious and concerning symptoms?
The most common symptoms we see and what people most often come to us concerned about are debilitating fatigue. In many people, that's associated with something called post-exertional malaise or post-exertional symptom exacerbation, which means you feel an intense exhaustion. Some patients describe as if every part of their body is completely drained of energy after sometimes minimal activity. So someone will wake up in the morning, go to make breakfast, and after doing that, they have to lie down and they feel almost incapacitated. There are others who feel fatigue that they're able to do their normal activities, but the next day, after having a busy day, they feel a physical illness, which is that post-exertional malaise. Many people actually think they got COVID again, or they think they've been infected. So fatigue is a very common one. The cognitive changes in thinking, memory, focus, and attention that impact people's ability to work, sometimes to do common things around the house, like remember that they're cooking, they walk away and forget that they're cooking. That's a common symptom. The racing heart and feeling those types of symptoms, which we classify as dysautonomia, an issue with the autonomic nervous system likely, is a common area. And then some other ones include pains like burning, sharp pains, numbness, tingling, nerve type pains, changes in digestion, shortness of breath, I should say. Shortness of breath is a very common one. And we see people also who their primary issue has been their taste and smell has never returned. They otherwise feel recovered, but everything tastes rotten to them or tastes like metal, and they're not able to enjoy foods. So I'd say that's probably the handful of most common things people come with, although, like you said, there are many things people have experienced head to toe, which I think each one could be equally distressing or equally concerning. So it's not that one is more important than the other, but those are the most common ones.
Thank you. Is there a difference? Is there a difference in the terms post-acute sequelae of SARS-CoV-2 and long COVID? To give you an idea of what I mean, a person who's been hospitalized with severe COVID and develops kidney failure as a result, would that person on returning home who might remain in kidney failure be labelled as suffering from long COVID? Or do those that suffer from long COVID have their own unique signs and symptoms?
That's a great question. I think the terms came from different sources. So long COVID arose within the patient community as a term that emphasized the fact that it wasn't necessarily that this was post-COVID, that they were experiencing issues from COVID that could represent a continuation of that disease, and was a slight change in labeling from calling something a post-COVID condition, which was one of the terms used in the scientific community. Post-acute sequelae of SARS-CoV-2 was, I think, originated from the National Institutes of Health in the US, and is essentially getting at, is a scientific label for an illness after the acute phase of the illness, which I think from a historical perspective is appropriate because there's also other post-acute infectious syndromes that fit with what we're seeing. So it's kind of easy to refer to that, but I frequently just use long COVID because it's simpler. People are very familiar with it. In terms of your question about people who have been very sick in the hospital and have persistent health impairments afterwards, there is a distinction because whether it's from COVID, from the flu, from a bacteria causing pneumonia or other infection, we've known for a very long time people who become very ill, especially from infections in the hospital, suffer long-term consequences in their health. And it could be because their kidneys failed, because they were bedbound for weeks and they have to recover from that. Or it could be changes in cognition, thinking and memory, just like we see with long COVID. But it's probably a slightly different process within the body to become this sick after a mild virus versus to have difficulty recovering because you were severely sick in the ICU or in the hospital. Being severely sick is probably, regardless of the cause, the reason why you have difficulty recovering, whereas long COVID, for the most part, is being used to refer to what could be the underlying biological reason that after getting a virus, even a mild infection, you begin to have a host of new health issues throughout your body. And I think that's a different process.
Which brings me to my next question. With so many symptoms associated with long COVID, do you believe that as research progresses, we will find that COVID-19 has led to a cluster of disease processes rather than just one termed long COVID?
I think from what I see with different patterns in patients, the different types of symptoms and the different, what we might use the term phenotype, which is kind of a description of certain patterns of symptoms. We may see 10% of our patients have this pattern, 20% have a different pattern. We certainly see, that's what we're observing. That's what I see as I see now, having seen many hundreds of people with this. There are some with very distinct clusters and respond to specific medications well, others who have no response to those medications and have a different cluster. So I think at the very basic level, it may relate, what we're learning at least, to a change in the immune system. The immune system becomes active to fight the infection, but doesn't shut off as it should. But within each person, there may be a different way that manifests. There may be specific immune cells that are more active in one person than another that could lead to impairments in one area in response to one set of medications versus another. So I think it seems to be diverse enough that we'll learn from the initial injury of COVID, the body responds in slightly different pathways, and that could lead to these different clusters of symptoms and different responses to treatments, which is unfortunately it's common for almost all diseases. And what makes medicine challenging is that even one drug for one disease can cure one person of it and not help another.
Mm-hmm. Yes, very interesting but distressing for those suffering. Um, what is remarkable to me is that people who have never had any COVID symptoms, i.e., those who have tested positive but are asymptomatic, can also go on to develop long COVID. Do you have a theory as to why?
Um, that's a great question. I don't know the exact answer to why that's the case. And just by the nature of people recognizing long COVID as being associated with having had COVID with at least some symptoms, almost everyone we see had a period of time where they felt ill, and then the long COVID followed that. It's less common that people come to us having had a positive COVID test, no symptoms, and then later on develop symptoms. So I don't know how common long COVID is after asymptomatic infection, but for the same reasons that it's causing this in mild infection, it could simply be that the virus is stimulating a change in the immune system, not to the degree that causes severe illness, but persists at a low level, say, and causes other health impairments because it doesn't shut off appropriately. So I think it's possible that it could be after asymptomatic infection, though most of the patients we see can point to some symptoms, even if it's a very mild illness when they were initially sick.
Hmm. Has there been any definitive research that indicates for how much time an individual would be expected to suffer with long COVID?
This goes back to the different clusters of patients or buckets people seem to fall into.
Mm.
We see certainly very distinct groups in terms of people who have similar long COVID issues. They feel short of breath or they have brain fog. Yet when we follow them by 9 months, they feel back to normal, versus people who have no change over time, or a group of people, I would say it's not uncommon for people who have had very long symptoms that they have ups and downs. They have a period where they thought they were completely over this, and then something happened. They may have gotten COVID again, or they may have had a stressful time in their life or had some other illness, and their symptoms flare back. So there's that group that has kind of a roller coaster of ups and downs. So it kind of depends on what group someone falls into in
Mm.
terms of guessing when they might feel better or at least very close to normal. And as we follow people over the first 6 months or so, it gives us a fairly good understanding of which group they might fall into, because people know themselves well and they can say, compared to 3 months ago, I feel so much better. I'm not back to normal, but I'm dramatically better. That's much more reassuring than seeing someone who every month has an up and down, and we can't quite get a grasp on what's causing these continued flares of their symptoms.
Is there any evidence-based research to show long COVID patients that have had significant improvement in their symptoms can completely recover, or will long COVID stay with them for life?
Lots of the research has focused on different symptoms over time. It's been fairly limited in that it has done surveys or other ways of engaging patients to describe what they're experiencing. There haven't been as many studies that have very rigorously followed people systematically, say every month or every few months. That's actually something that we're involved in right now, is this large national study throughout the US that intends to follow people over years. But what I've seen so far for specific symptoms are things like people who even by 4 to 6 months still have changes in smell and taste. Most of them have recovered when they're followed up at 1 year. For people who have very fast heart rate in the early months after COVID, which is a common thing we see, the heart is going faster than expected with activity. Most by 6 to 9 months seem to have resolved that symptom. For other symptoms like fatigue and brain fog, cognitive changes, those appear to be the most persistent among people who have persistent symptoms. Fatigue and brain fog or cognitive changes tend to be two of the ones that are experienced by most people in that group. So it really seems to vary by the individual symptom. And we've seen at least that it definitely seems to vary by when people are able to get care, whether it's medications to treat their symptoms or rehabilitation to help their shortness of breath or other forms of treatment. There certainly seems to be a benefit that we're finding in our patients, and patients when they enter into our clinic, I feel are continuing on the path of recovery, even if they're not fully back to normal. It's uncommon for people to be worsening or not feeling better over time. Most people do every few months say that they're continuing to recover and they're continuing to feel better.
Oh, that's really good to hear, actually. So I may be a bit presumptive with this question, but from your own encounters as a physician caring for this patient group, have you experienced a patient fully recovering from long COVID that can be declared cured of long COVID?
Yeah, I think so. I certainly have had patients who feel fully recovered. They generally fall into that group who by, I would say, 6 to 12 months are experiencing that recovery. Patients who are seeing us who are 18 months out, I guess the nature of them seeing us is because they still have symptoms.
Yeah.
So there's a bias to who we're seeing, but we certainly have seen people who feel fully recovered. I guess the term cured may depend on us understanding what the actual cause of long COVID is and being able to test that, which is something that we don't currently know and can't do. So I'm hopeful that we'll learn through these studies what to follow and what to test for that will help us know the body is no longer having the problem that caused long COVID. We do have a concern sometimes when people feel much better that could be a risk of symptoms flaring in the future. And that could happen if they got a new infection. I've had people who have felt cured and then had a second infection with COVID and their symptoms returned to some degree. So that makes me think if it is something such as the immune system that has not properly regulated itself, they could be at risk for that with future infections. So that's kind of where I stand on cured, but people recovering from symptoms, we certainly have seen. And we've seen people who, without new infections or new triggers, have felt completely back to normal.
That's encouraging. Do you have any idea of what proportion that is of the people you see?
It's going to be slightly biased because people with the worst symptoms come to us, and there's also unfortunately a long wait for all COVID clinics because of just the sheer volume of people experiencing this. So we do see the sickest of the sick people. I would say probably a third of the people we see fall into that category of they come with bad symptoms, yet we can tell as we follow them with time and we look back in time, they're clearly improving and they get back to a place where they feel, say, 95, 97% back to themselves. That's probably a third of the people we see. And the other 2/3 were either seeing slower progress or they may feel better and then have a future flare and have more of that up and down, coming and going aspect to their long COVID.
Numerous important studies have been launched to look at how COVID-19 leads to long COVID. This has resulted in a range of hypotheses being proposed as a cause of long COVID. And to give just a few examples, a change in gut microbiome, its classification as an autoimmune disease, One really interesting one to me recently was latent viruses in the body, such as the Epstein-Barr virus, which causes mono or glandular fever, being re-triggered by SARS-CoV-2, and so on. So, is, in your opinion, the most likely cause or causes of this syndrome?
In my opinion, the most likely theory to bear out as being true is a change in the immune system after having COVID-19 that's leading to persistent low-level inflammation or injury in different parts of the body. What's triggering that? We don't know. There are, even below that level of theory, there are theories that it could be persistence of parts of the virus that the body is still feeling, although there's not active infection going on, that viral remnants are still triggering the immune system, or that in autoimmunity, meaning that the body's immune system is, in a sense, attacking itself, has been triggered. There have been some clues to that type of process, but nothing definitive. But I think it all centers around an inappropriate response of the immune system being persistently abnormal for much longer than you would expect after a virus. I think other things like finding Epstein-Barr virus, which is a very common virus that people may have latent in their bodies, it doesn't point to that being the cause necessarily, because it's quite common that that's found in different infections and different inflammatory states. So I think it's probably just a clue to the fact that the immune system is not properly regulating itself, more so than that Epstein-Barr virus itself being the explanation for long COVID. It's probably just a sign of the issue within the body.
Right, okay. So when you term viral remnants, you actually mean viral remnants of SARS-CoV-2 rather than viral remnants of something else that we may well have caught.
Yes, yeah, that's one of the theories, is that could be a trigger. And it's very tough to answer that theory, because the only way to really look for virus in detail is if someone has unfortunately died and we can do an autopsy. And those are usually people who get very sick in the hospital, not people who are young and otherwise healthy and then got COVID and are living with long COVID, but it's hard to understand within their body what could be going on without getting the right tests.
Long COVID is known to disproportionately affect women more than men. Do you have any idea why this could be?
So I think telling the demographics has been tough, because in some cases, the surveys have engaged social media groups or other groups who may skew towards a different demographic depending on who is most engaged in that group and who is searching for answers as part of that group. So we certainly see a spectrum, men and women, and all races and ethnicities affected by this. And I think that makes sense to me. There are parts of long COVID, like having a very fast heart rate with activity, that has been seen after other viruses or as part of a syndrome called POTS, postural orthostatic tachycardic syndrome. That has tended to be younger women more often than men, and more often than older people. And I don't think it's very well understood why that's the case. The MECFS is another component, a syndrome that we see reflected in long COVID, which stands for myalgic encephalomyelitis chronic fatigue syndrome. That has also been described for a long time after other infections, and also sometimes for unknown reasons people develop this, but they frequently are able to point to some initial illness and initial infection. In studies of that disease that have gone on prior to the pandemic, there have been clues that there may be genes, genetics, that make one person more susceptible after an infection to developing it compared to others. So I think probably the reason that so many people are having the same virus infect them, and some recover and some develop long COVID, would have to do with differences in the genetics and how the bodies are responding, which could then translate into differences among demographics.
So that's interesting. So you actually think there's likely a genetic rather than a sex or gender difference that could be leading to an exacerbation of symptoms?
I think probably for the same infection to lead to such varied responses in the body, the genetics, or something we call epigenetics, things that also not just your genes, but modify the activity of genes. There could be so many reasons why one person is prone to having this completely different response to the virus than another. And we see that in acute COVID too. Some people get very sick and die from COVID, and someone else who seems to be the same age, the same gender, otherwise seems exactly the same, has a mild illness. So there are a lot of factors related to how the immune system responds to infection that differ between people. And there are things such as genetics and other factors that modify the activity of genes that could be why there's such a different response.
I guess it would be really interesting to do some twin studies, to back up that argument. Do you know of anybody who's doing that?
Yeah, that's an interesting point. I don't know off the top of my head about twin studies, but that is an area where people can use identical twins and understand, and also can use people adopted at birth who are twins to understand the relationship between environment versus genetics on illness. But I don't know of that in long COVID.
Thank you. Long COVID seems to affect one or many different parts of the body, involving potentially many medical specialists becoming involved in the sufferer's treatment and recovery. Can you please tell us about your approach to providing care for these patients?
Because it affects so many parts of the body, and we recognized even early on from patients surviving the ICU that there were many different areas affected that no one doctor or one therapist or clinician or nurse could help address alone. Our approach was to put together a team of people who really act as a group centered around the patient's needs, and we modify who's involved with each patient depending on the individual patient's needs. So some people may primarily have issues with their thinking and memory, and they need to focus on seeing our cognitive neurologist and our occupational therapist who specializes in brain rehab, and a neuropsychiatrist who also specializes in brain rehabilitation. All of those people are kind of part of the core team, and then you can easily streamline patients getting into each one of them much more than you could if you were just you were a primary care doctor in a health system and you're just trying to refer patients to different areas. And then the second benefit of creating that team is that you begin, by virtue of specializing in this, seeing a very high volume of patients, and you gain a level of experience quickly that other people just simply don't have because they're not focused solely on this. And so our practice and how we treat patients begins to be informed on a week-to-week basis by what we're learning from seeing so many patients. And it's a feedback where we can develop processes of care and see what's working and what's not in a way that wouldn't be possible if we didn't have a high volume specialized team.
That's fantastic. So I guess it's what's called a multidisciplinary team with many different, medical specialists and other medical professionals being involved.
Yes, yeah, that's right. We have very important, outside of physicians, social workers, physical and occupational therapists, a nurse who coordinates all of this, the staff in our clinics who help to coordinate the care as well, and then researchers and people who are doing things like breathing therapy with patients who have backgrounds in yogic breathing, people who are helping with the research to understand what's going on. So many areas of the team and many different disciplines involved.
That's fantastic. This virus is a new discovery in medicine and science. Your experience with post-intensive care syndrome must have been invaluable to the work you are doing today on long COVID. Please explain post-intensive care syndrome to our audience, and could you relate how this clinical and research experience fed into your clinical care and research of long COVID sufferers?
Yes, thank you. So over 20 plus years, research had been showing that people surviving being in an intensive care unit on breathing machines, on ventilators, or having severe infections in the intensive care unit were leaving and suffering from changes to their thinking. They were testing on the level of people with dementia at times in terms of their thinking. They were physically debilitated because they were bedbound and for so long, and they were sick and their muscles had wasted and they may have other injuries. And they were suffering from post-traumatic stress disorder, anxiety, depression. They may have had continued shortness of breath because their pneumonia had scarred their lungs. So all of these issues became termed post-intensive care syndrome, which refers to these persistent health impairments that occur after being in the ICU and persist after leaving the hospital. And they generally fall into those buckets of physical impairments, mental health impairments, and cognitive impairments, although there are now many other things layered on top of that. That issue, post-intensive care syndrome, was, at least in the US, not very well addressed by health systems. There were only a few clinics that existed prior to the pandemic that were focused on ICU recovery. And it was very, very limited getting actual specialized access. The pandemic was a catalyst for many of these clinics opening up, including ours, because suddenly health systems saw the issue and it was being recognized by the public, and they were motivated to invest and to support these. Whereas prior to this, a lot of it fell into the research domain and didn't make it over into the space of actually helping patients clinically.
Wow, that's something positive to come out of all of this, really.
Yeah.
That's really cool. You treat both hospitalized and non-hospitalized long COVID sufferers. The presentation of symptoms for long COVID and post-intensive care syndrome are similar. How do you distinguish between the symptoms caused by long COVID from the symptoms caused by post-intensive care syndrome?
Yeah, for post-intensive care syndrome, because there's a fair amount of experience with it prior to COVID, we tend to really, if people are coming out of the ICU, focus on those issues which do have some overlap with long COVID. So there are people who have changes in cognition. There are people who are physically debilitated and need very intense physical therapy. And then others with mental health issues or shortness of breath. So we tend, after the ICU, to really focus on the big steps of recovery, going from someone who has been in the hospital bedbound on life support to it walking around, basic functioning at home, those types of things. And then over the coming months, we're able to see, is someone kind of continuing to progress and recover in the expected way? Or are there other unique aspects to what they're experiencing that we see with long COVID, like the taste and smell haven't returned? That's something that we wouldn't routinely expect with post-intensive care syndrome and is more unique to this virus, that they're having unexplained pains throughout their body. That's something, again, we see commonly with the virus. And there are some other examples of things that you wouldn't simply expect related to being critically ill and maybe more unique to long COVID itself. But the approach is generally get the big picture of recovery settled out, which is largely post-intensive care syndrome issues addressed. And then over time, understand as they're recovering, are there new issues emerging, or are some of the issues persisting that we think we wouldn't expect to persist in this way if it was just critical illness alone and not long COVID?
So, in actual fact, you're in a very good position because you see those two different groups to sort of tease out. The two different types of symptoms, it's actually a very good position that you're in from what I can ascertain. Am I correct?
Yes, I think so. And it's a bit up to the individual patient how I think long COVID has gotten so much recognition. People may feel more support if they're labeled or they self-associate as having long COVID, and there are other people experiencing these things. Post-intensive care syndrome, though it was known in the medical world, was not really known to the public and even not known to most doctors. So I think there is also a benefit in just the community of support that you get from being someone who has long COVID, whether it's, we think it falls more into a post-intensive care syndrome bucket or it's more of a long COVID bucket.
Could you please share with us the specific research that you're doing with respect to long COVID?
So our research spans a few areas with long COVID. Early on, as we began to see people with shortness of breath, many of whom were having normal testing performed, and we couldn't find an issue with the lungs themselves that fully explained this, we were wondering how we could help people rehabilitate from that, knowing that they were safe to do so because their lung function was preserved. So we've been doing a randomized study of specific types of breathing exercises to improve the breathing comfort for patients, to improve their strength of breathing, and to improve their ability to breathe comfortably while active. More recently, this extensive study across the US through the National Institutes of Health is called RECOVER, and it's going to be enrolling people who either have long COVID or are at the time of having their COVID infection are acutely sick, or people who have not had COVID as far as they know and are healthy, and so we can use them for comparison. And we're doing detailed testing, blood testing, questionnaires, as well as potentially, depending on symptoms, tests head to toe like brain MRI, lung function tests, other things to get at what exactly is causing these symptoms and what could explain long COVID and how do people recover in these different groups. So how, as we test them over time, are their symptoms changing?
Thank you. Recent studies in Israel and the US have indicated that vaccination possibly prevents long COVID or reduces the severity of long COVID symptoms. In your opinion, when we are vaccinated against SARS-CoV-2, what is happening in the body to cause this?
So when we're vaccinated against SARS-CoV-2 or pretty much any vaccination, the idea is to produce a memory within our immune system for that infection so that the infection, in the case of this virus, which may be in your nose, along the lining of your nose as you breathe it in, can only get that far. And when it enters the body, it's cleared quickly because your body has a memory of this infection and it removes it. It has antibodies, which are things that attach and remove infection and activate a process that ultimately removes the infection from your body. So the biggest difference in someone vaccinated versus unvaccinated from that perspective is really the body entering and the virus entering and spreading throughout the body in a way that can be harmful. If you're vaccinated, you can still be exposed to the virus. You can still breathe it in. It can still get on the lining of your nose. And that's why you can still test positive potentially at the time that you're exposed from a swab, but it won't successfully get in and spread throughout your body and it won't make you sick. So I think the biggest difference is early rapid clearance of the virus within the body, preventing it from spreading throughout the bloodstream to tissues and affecting tissues potentially with inflammation. And that seems to fit with the idea that abnormal immune system activation is explaining long COVID and persistent inflammation throughout the body could be explaining long COVID. if you prevent that from happening in the first place by clearing the virus immediately through the memory that your body has from vaccination, then you could prevent long COVID. And that's what we're seeing in these studies that are early, and they're preliminary. Some are not yet fully reviewed by the journals that they're submitting to. But they seem to be good quality, and they suggest, one of the recent studies I've seen from Israel, that full vaccination is more protective than single dose and is much more protective than unvaccinated. So it fits with this theory, and it kind of supports this idea that clearing the virus quickly could prevent long COVID.
That's an excellent explanation. I can sort of qualify that in my mind. So when you say full vaccination, do you mean 2 shots, 3 shots?
So this study was done with 2 shots, I believe, of the Pfizer vaccine. At this point, I would consider someone a full protected vaccination with 3 shots. And that's been shown very clearly with data with the Omicron variant, that 2 shots are not fully protective in the way that 3 shots are. And certainly for someone who is at higher risk because of their age or other illnesses, or their immune system is compromised, then they definitely need to have full vaccination, including booster shots, to be protected.
Yeah, thank you for that excellent answer. Despite the worldwide record-breaking number of COVID infections caused by the recent Omicron wave, we have been told by politicians and some in public health that we need to live with COVID-19. Countries all over the world are rushing to roll back public health infection control measures, such as requirements to wear masks or to be vaccinated to enter public spaces. In some countries and regions, access to testing has been reduced, contact tracing curtailed, and cessation of the need to quarantine if you test positive. It appears with this approach that some are advocating a policy of letting the virus rip through our populations unobstructed. What is your opinion of this approach, and what impact do you see this having on long COVID?
So I think we expect long COVID can continue to happen, unfortunately, from this virus as it spreads. And so the decisions from a public health perspective and for each individual person of how they want to protect themselves could impact that. You could be at higher risk if you're not vaccinated and you're in public places and you don't wear a mask. You would be at high risk of getting the virus, and then you could get long COVID. If you're fully vaccinated and you take measures to avoid crowded spaces indoors, or you wear a mask indoors, then you're at lower risk. The actual public policies that are decided are tough, because everything in medicine is a benefit of risk, is a balance of risks and benefits. And people often outside of medicine have a tough time conceptualizing that. And policies are kind of a blanket thing. So everyone is affected by them, yet within even a state or a town, there are going to be people with polar opposite views on this risk benefit. Some will be more comfortable being more careful, and some will want to be less careful in terms of exposure to the virus. So I think the main answer to the changes is that we will unfortunately continue to see mild infections. That's going to be the reality of the state of the virus, and the rate of vaccination in different regions will affect that. We're hopeful in the regions like I live in, where there's a very high vaccination rate, that will be protective against long COVID in the same way it's protective against COVID infection and severe illness from acute COVID. So that will benefit those areas. In areas where the virus is spreading and there's a low vaccination rate, they're going to have, I would expect, higher rates of long COVID as well. And in some of those areas, unfortunately, they may be less prepared because they're not large cities with long COVID clinics, or they may be less well resourced. And so that will be a challenge as well, getting access to care for people experiencing long COVID who are in an area that they don't have large hospitals or university hospitals with these clinics.
Long COVID appears to be the forgotten aspect of this pandemic. Initially, the medical community did not believe people were suffering from long COVID. As a result, people set up their own online support groups. Some don't want to hear about long COVID or acknowledge it exists as an important byproduct of the COVID-19 pandemic. Yet we see numerous examples of well-known individuals, such as Olympic athletes or professional athletes in their peak physical condition, who have had their career trajectory altered and in some cases their career ending because of long COVID. Why do you think long COVID is being ignored by so many when there is so much evidence to the contrary showing it is doing damage to so many?
Yeah, that's a great question. I think the why is tough to get to, but is unfortunately not too surprising that people have been discounted for illnesses that weren't clearly measurable or didn't clearly show up on some test. And even among people who have illnesses who show up on some tests, they're discounted for a variety of reasons. So I think medicine had people skeptical as well as outside of medicine. And we see that we still continue to see this, people skeptical of, well, is this real? How much of the symptoms are people exaggerating? Are this people who come to our clinic even tell us among friends and family, sometimes they have a tough time with people saying, you know, these other people were sick at the same time and feel fine. Why do you still feel this way? People have that problem with employers sometimes as well, as they are feeling these changes in cognition, this exhaustion, pains throughout their body. And because it doesn't manifest in a very easily measurable or tangible thing like a CAT scan result or a test for cancer or something like that, I think it's easier for people to be doubtful of it, especially if they're not deep within this work and clearly seeing this is obviously an injury after the virus. This has been described for centuries. We know a fair amount about how other viruses have affected people in terms of syndromes, and we're learning a fair amount about the actual changes with long COVID. And I'm hopeful that the recent research, especially this year as research is really ramping up, our understanding of the biology of long COVID is ramping up. There will be clear high impact studies that kind of wipe away any doubt that people had. But as you've seen, and we've seen throughout the pandemic, even very obvious tangible things can be discounted or ignored by people. And that's, I think, part of human psychology and not necessarily unique to any virus or any illness.
In 2026, the first baby boomer turns 80. Our medical systems are already stretched thin. With an aging population as a certainty in the next few years and the potential additional cost burden on the medical system with long COVID, how do you think we can manage these pressures going forward?
So I think certainly investment in primary care and general medicine care, and investment in teams that manage illnesses in ways that center around the patient's needs and bring value to the patients rather than ways that produce revenue through testing or treatments. That type of focus, which is kind of value-based healthcare, compared to what we call in the US fee-for-service, which is you have something done and the insurance pays for that specific thing to be done. Having a value-based mindset and having insurance coverage that focuses on patients' outcomes rather than just services is going to certainly serve patients well. We're hoping, at least from a long COVID perspective, to have investments through federal grants or other programs to support the continued buildup of long COVID clinics, because there are already too few. We're already overwhelmed. And if you rely on each COVID clinic to try to support itself, it's going to be quite challenging. So we're trying to advocate for some organized national program that supports the development and growth of long COVID clinics, both from a clinical and research perspective. But I think caring for an aging population will hopefully require a continued shift in the right direction of how we provide medicine, that we focus on prevention of disease, not treatment of illness once it's happened. And we actually truly put our money where our mouth is in that, because for the most part, healthcare, things that treat more serious diseases pay more, procedures are more desirable financially from the global healthcare perspective than a preventative treatment. And we have to continue to shift to value-based healthcare and preventive healthcare for aging populations.
Thank you for that answer. Post-pandemic, let's look at people that have had COVID-19. About 400 million people in the world to date, which is likely to be an underestimate, have had COVID-19. So from that figure, around 60 to 120 million people will be expected to develop long COVID. With this figure set to increase as more people become infected, do you believe that long COVID will have a greater economic and societal impact than the pandemic itself?
It's hard to do a direct comparison. I think it will have a substantial impact, and it could be a very big enduring impact in terms of employment, joblessness, because tons of the patients we see have to leave their jobs because they can't function in the jobs. So I think the workforce issues will continue in part because of long COVID. Those buckets of patients I talked about, people recovering versus having continued illness, it's hard to know amongst the millions of people having COVID how many people will fall into each bucket. So I'm hopeful with vaccination and with what we're learning about long COVID, we'll be able to help these patients in a way that we weren't able to do at the very beginning when this was first recognized and we knew nothing about it. But I think the pandemic itself has had catastrophic worldwide financial implications. I think the implications of long COVID will be really on the workforce and on the quality of life and the lives of all these people affected, which may not be easily reflected in a jobs number or an economics number, but will be people living with these chronic illnesses that have changed the way they experience or enjoy life. And that in and of itself is a huge deal.
And I know we've nearly run out of time, so this is the very last question. I'd like to end on a positive note. What have been your most uplifting experiences of this pandemic?
I think the most uplifting thing from a long COVID perspective is just how resilient people are, that people come to us with these intense impairments and changes to how they're feeling and experiencing life, yet they've continued to go, they're raising their kids, they're at home. And even when we don't have an easy answer and we listen to them, just by developing a relationship with them and having someone listen, people are so grateful. And that is a very simple thing that you can do. It doesn't take really any specific medical expertise, but it's something that for patients who are being ignored is often not provided to them. No one is listening. And so I think the simplicity of developing relationships with people by listening and believing their symptoms and by partnering to help them feel better, even if we don't have a simple cure, has been an uplifting part of this, and seeing the resilience that people have.
Thank you so much for such a fantastic interview. It's been very informative, and we're so privileged to have an expert such as yourself join us today. Thank you for all that you do. Your patients are very lucky to have such a dedicated healthcare professional looking after them. Thank you.
Thanks. It was my pleasure. Thanks for having me.
Thanks for listening to this week's episode of COVID-19 The Answers. If you enjoyed the episode, please subscribe, rate and review, and do visit our website kajalamedical.com/COVID-19 The Answers.